All right, hello to you, our listeners, the manipulated and the manipulators. Welcome to the OMM Research Podcast. The OMM Research Podcast is produced by DO-Touch.NET, a practice-based research network that focuses on osteopathic manipulative medicine research. DO-Touch.NET is based out of the A.T. Still Research Institute, located at A.T. Still University in Kirksville, Missouri. Please note that the views and opinions of the panelists in this podcast are personal to each panelist and do not reflect the views or opinions of A.T. Still University. My name is Corey Lubring, and I am the practice-based research coordinator for DO-Touch.NET and the host of the OMM Research Podcast. We want to remind our listeners before we get started that this podcast recording has video recorded with it and can be viewed on the DO-Touch.NET YouTube channel. We want to start off the episode by introducing our panelists for this episode, and we'll start by introducing Dr. Stephen Stacey.
Hello, my name is Dr. Stephen Stacey. I'm the Director of Osteopathic Education at the La Crosse Mayo Family Medicine Residency Program, and I am an Assistant Professor of Family Medicine at Mayo Clinic. And if you're watching this on YouTube, then the good news is my camera isn't working right now, so you don't have to deal with my face.
Well, we're still happy to have you nonetheless, even with camera off. And then, of course, we have Dr. Alfred Amendolara.
Hi, my name's Alfred Amendolara. I'm a PGY1 in neurology at St. Luke's University Health Network in Pennsylvania, and I'm also adjunct faculty at Norda College of Osteopathic Medicine in our clinical research department.
And thank you for being with us again this episode as well. So we're going to start out with an article that was brought to us by Dr. Stacey that is looking at manual therapy for neck disorders.
That's right. So that is the title of this article, Manual Physical Therapy for Neck Disorders, an Umbrella Review. It's written by Reynolds et al., published November 28th, 2024 in the Journal of Manual and Manipulative Therapy. It is an umbrella review that seeks to answer the research question in patients with neck pain, is manual therapy effective as compared to other physical therapy interventions, medical interventions, or a control for improving pain, disability, or fear? And that's directly from the article as their PICO question. PICO, how do you guys pronounce it?
Pico is what
I
I've
always say
heard.
pico, but
Yeah,
now you're making me second guess that.
well, so we're 3 for 3 here on Pico, but I have heard Pico before too. I just love Pico so much on like, chips and burritos and things, so I just got to go with that. So the as an umbrella review, this study answers a pretty broad question, and it does a good job digging into the details of some specific ways that manual therapy may be effective as an intervention for neck pain. Even though it doesn't study osteopathic manipulative medicine per se, I think it really helps inform our multidisciplinary practice. So I thought this was a good one to review.
So, as an umbrella review, I'm interested to see how big this umbrella is they're casting. So, could you give us a little bit more insight on what the methodology is for this study that we're looking at here?
Sure. So for those not familiar with an umbrella review, it is a systematic review of systematic reviews. So for something to be a systematic review, it just means that you publish the methodology by which you search for articles of interest. So you would say search criteria, you would say inclusion and exclusion criteria, and just like you have subjects that you may enroll for any other type of study, in this case, in a systematic review, the subjects, if you will, are published articles. And in an umbrella review, the studies you're looking for are other systematic reviews. And the idea is to put together a wide variety of evidence to shine the light from multiple directions onto a clinical phenomenon of interest. And in this case, they chose physical therapy, manual interventions as a treatment for neck pain. And they had a few different outcomes that they looked at from the different articles as they were putting them together. So they found 35 systematic reviews and meta-analyses published between 2016 and May 2023. They followed PRISMA guidelines, which is what you would expect, and they assessed methodological quality via AmStar2, which is a tool that you can use to look at the articles to determine how methodologically sound they were. They reported on the quality of the different studies, and then they ranked the conclusions of the different uses and outcomes of manual therapy according to the quality of the evidence supporting them, not necessarily ranked by the strength of the clinical effect, if that makes sense.
Not so much to me, but I'm not
So,
a DO, so but yeah, continue.
well, so one way they could have sorted it would be to say, which one has the biggest clinical effect, but what they did is they chose to sort it by which one has the evidence with the least risk of bias behind it, which I thought was
Ah,
appropriate for the style of um, study that this was.
that makes sense to me.
So they had 35 studies and they had high confidence for 10 of the reviews, moderate confidence for 12 of the reviews, and low to critically low confidence for 13 of the reviews. And they noted a great deal of heterogeneity and varying risk of bias in the underlying primary studies. There was a handful of studies that were reviewed multiple times in the different systematic reviews, and they noted this as a potential limitation in the umbrella review methodology, is that certain studies may be weighted more heavily because they're getting magnified through multiple systematic reviews, but it was a small enough number that I think we can still pretty well trust the data here.
Sure.
So the conclusions,
Yeah, no, continue.
oh, go ahead.
No, you led into what I was gonna segue into. Continue.
Oh, see, great minds think alike, and so do we. So they looked at non-specific neck pain as the evidence, or as the outcome with the greatest strength of evidence, and they found high confidence evidence that manual therapy combined with exercise was superior to either intervention alone in reducing pain and disability in the short term. They looked at cervical radiculopathy and they found moderate quality studies creating moderate evidence supporting neural mobilization, distraction, soft tissue treatment, immobilization, and spinal thrust manipulation of cervical and thoracic spine is effective for pain and disability. And this brings up to, you're hearing a lot of different types of therapies that are being studied here. So we say manual therapy, but they mentioned spinal thrust mobilization, they mentioned distraction, traction, neural mobilization, soft tissue work. So there's a variety of different techniques being involved here, which in a way almost might be like saying, surgery as a treatment for neck pain, noting that there are many different types of surgery, which I think could still be appropriate for an umbrella review like this because they are doing their best to sort of, as much as the primary literature allows, pull out those different types of outcomes and
Hmm.
different types of techniques and say what's the evidence for each of these. And they also mentioned they have high confidence evidence supporting the use of cervical mobilization or manipulation, soft tissue mobilization, and manual therapy plus exercise in improving pain and disability in patients with cervicogenic headache. And they did note that they emphasized several times that the best evidence shows manual therapy being used in conjunction with other types of treatments in a multimodal approach that would involve things like home exercise programs, stretching, um, mindfulness meditation, neural feedback modulation, pain neuroscience education, and that manual therapy is effective on its own, but most effective when used as multimodal therapy, which I think pretty well agrees with a lot of other research that we see about pain management in general is that any single treatment is not going to be as effective as a multimodal therapy. So I admire that the authors are highlighting that with their review and really showing good evidence behind that.
Mm-hmm. Al, anything jumping out at you? Anything you want to add?
I don't want to just spout off some of the same things that Stephen just said. I'm a sucker for this sort of meta research. I really like it. I think this was a well put together and well thought out attempt at it. I it's hard to really find faults. To some extent, the limitations they address are ultimately the limitations of the underlying data that they're basing on. In their case, it's other systematic reviews, and of course, those systematic reviews are inherently limited by the studies that they are including.
Mm-hmm.
So in manual therapy, osteopathic research, and other kinds of manual therapy, I think this is a difficult problem to overcome. But I think their results and conclusions are very reasonable. I think that their contribution to this sort of broader meta research is useful, and it does a good job in answering a clinically relevant question with something that I feel like a practitioner out in the field, the boots on the ground kind of people could look at this and make a reasonable change to their practice or have confidence in what they're doing has reasonable support behind it.
Yeah, I 100% agree. And they do a really good job pointing out those limitations. One of the things that when you're looking at an umbrella review is to just ask, have they chosen the right question for an umbrella review? Is the
Mhm.
underlying research that's been done enough to justify the presence of an umbrella review? And in this case, I think they chose the right target here because there is a number
I
of
agree.
of systematic reviews that have come to different conclusions. And this is a good time to have somebody put all those together and compare the strength of evidence and come to a synthesized conclusion. And they point out appropriately that really what is needed now is potentially not quantitatively more research, but qualitatively better research. I don't think doing more of the same kinds of studies that ultimately went into these systematic reviews is going to necessarily change things much now. If we want better evidence on this, we have to rethink the questions that we're asking and coming up with different ways to probe at the boundaries of what we know. So, for example, if we know that a certain type of manual therapy could be effective for treating neck pain, we could ask ourselves, what is the minimum amount of training somebody might need to achieve that outcome? Is it something where you need all 4 years of an osteopathic medical school? Could you do the same thing with a week-long training? What about an hour-long session at a CME event? Do those people get similar outcomes? As just an example of the kinds of questions, now that we know that you can use manual therapy for neck pain, how can we further understand how manual therapy can interface with neck pain? So I think that this article sets us on a really good footing, re, from a research perspective, to start moving the field forward with manual therapy for neck pain.
Well, that's really interesting. That's a really good point to bring up. I know that's something that we haven't really talked about much, in some of our previous episodes and stuff about how, really this expands the boundaries of where we're looking at with further research after this. Um,
This one really does. It's a well-positioned review in the sense that there was enough data to even do this kind of review, and now having what appears to be a pretty good quality umbrella review that they've done, it lets us ask those other
mhm.
questions essentially, which
So if you were leading the research team, which direction would you step off this study towards then? Like, what would you feel would be a good direction to head?
Yeah,
yeah. So I think
oh, go ahead.
I was gonna say, like Stephen was saying, This sets the stage to be able to ask more questions with a good basis of understanding that, hey, there's evidence out there that this works. And we have this sort of now meta evidence, this meta research that supports it. So you can take a step back and say, well, what specific therapies work? What patient populations might this be more or less effective in? What type of practitioners can deliver this most effectively? So it gives a foundation now that we have some clinical evidence that we have an expected outcome, an expected positive outcome. We can go back and start to pick apart uh, why is there that positive outcome, and then what can we modify surrounding the treatment approach and the therapies to get better outcomes,
Mhm.
to pick patient populations, those sorts of
And we
questions.
we can get a little bit more granular with, as you mentioned, the patient population and the condition. So neck pain is a very broad category.
Mhm.
So let's say we have a patient with cervicogenic headache following traumatic brain injury, right? That's a much more narrow and focused population,
Mhm.
but it helps us direct specific treatments at specific people. So this actually lines up with some research we're trying to get off the ground looking at how do you quantify myofascial tension in patients um, with neck pain following traumatic brain injury? And what can you do from a quantitative standpoint to say how tense the tissues are? And
Mhm.
then if you can correlate that with clinical findings, then you could look at, what objective outcomes with the clinical findings, and then again point to, what are you seeing pre-post? And it's a more granular question. It's not as big a question as they asked, but science it weaves the tapestry one thread at a time.
Sure. And for those of you all listening and everything, whether you're listening on your podcast platform or you're watching this on YouTube and everything, we do have the journal links for these different articles in the episode description, whether it's on your podcast platform or on YouTube. So if you want to dive into these articles while we're discussing them and going back and forth on them, those links are provided below. So I do recommend getting in, looking at the methodologies, looking at the results and everything, so a lot of these figures and stuff. If you want to become better acquainted of the articles that we are looking at in these episodes.
And
But
while you're there, smash that subscribe button.
that's right, of course. And always, we want you to continue to follow along and subscribe, whether it is on YouTube or whatever podcast platform that you are listening to this, and continue to follow along as we discuss manipulative research. So thank you for an awesome article this week, Dr. Stacey. We're going to be moving on to our second one, which is brought to us by Al, and it is looking at lung function improvement after OMT correlated with the expanded zinc screen. I don't know. That's not familiar to me. I skipped over a couple things here, but Al's going to give us a bit more insight here.
That's okay. I'll get in a little bit of the necessary background, but so this study is a clinically significant lung function improvement for collegiate soccer players after OMT with restrictive ribcage motion correlated with expanded zinc screen. This is by Leung and Stiles, published in Journal of Osteopathic Medicine, just in October 2nd, 2025, or accepted and just recently published. So this study, the premise of this was to expand um, the screening for something called like a zinc compensation or compensatory patterns, which is this concept in OMM developed by a Dr. Zink for identifying somatic dysfunction specifically with fascia. So it's predicated on this idea of looking at fascial kind of tension patterns at various different levels in the body, and essentially states that the body can be compensated with these fascial tensions going in one way or the other, or they can be uncompensated, which is associated with somatic dysfunction. Um, this study in particular attempted to kind of expand that screening technique a little bit with their own addition, and specifically looked at a small group of soccer players, and then on top of that, treated some somatic dysfunctions they found, and then measured some lung function using spirometry to try and quantify any changes before and after this treatment. So this was, they call it a correlational study. It involved female college soccer players who signed up to receive this OMT treatment in addition to this zinc screening. It was at University of Pikeville. I think they recruited a total of 8 soccer players that they attempted to randomize into 2 groups. They found that all players in both of the groups, so I'll get more of this into the methods, but they found that all players in both of the groups had improvement in lung function and capacity as measured by the spirometry after treatment. And then they go on to make some rather grand conclusions based on this. Um, but essentially, they say that their expanded zinc screen is well correlated with somatic dysfunction, and that OMT can be used to effectively alleviate some of these somatic dysfunctions that can be leading to obstructive patterns of dysfunction, breathing dysfunction, or lung dysfunction.
So give us a little more insight to the methodology as to what you're kind of alluding to here.
Yeah, so I think we can start sort of at the top. This is a correlational study. They don't really describe much past that in their methods. Their method section is a little bit light on detail, but essentially they gathered 8 volunteers over the course of a soccer season, and then randomized them into a control group and an interventional type group. These groups were differentiated by their control group, so-called control group, had this traditional zinc screen, and the interventional group had this expanded zinc screen. They had 3 participants in the traditional arm and 5 in the expanded arm. And really, the difference was that they attempted to add a hypothesized list of factors. They describe dural and like muscular restriction types. To be completely honest, it was difficult for me to follow exactly what their hypothesized like screening additions were, um, because they don't describe them very well. And then they decided to measure spirometry. So spirometry is something that if I think most physicians should have encountered at some point in training, at least, and certainly if you're a pulmonologist or in primary care and dealing with patients with COPD or asthma, it's a very common way to measure lung capacity. And in this case, what we most commonly look at would be forced vital capacity and forced expiratory volume. And then you can get a ratio between those two, and they can broadly tell you if someone is having obstructive symptoms or restrictive symptoms and give you a clue into their pulmonary function and any diseases or disorders that they might have. So, a reasonable test for lung function, um, although a slightly unclear link between restrictive fascial patterns and overall lung function. Data
And
was
it,
then collected, sort of again vaguely described, and they did some analysis again, somewhat glossed over in the actual manuscript. And their main statistical finding that they land on is that one of the players had a um, obstructive pattern results on their spirometry, which then subsequently improved after treatment of OMT, which is really this is their kind of their core finding that they're basing their conclusions off of. That they had this one particular player who had a 20 to 30% improvement in their FEV1 FVC ratio post OMT.
It's
So,
interesting that they use the term statistical significance because I think there's
yes,
a lot of misunderstanding about what that might mean. So when they're saying statistical significance, it really needs to be to say how well do we think that this particular population represents the phenomenon of interest, out in nature. So there's a
so
truth that exists in nature, and we want to
as
say if I
best
do this, then that happens.
as best I can tell, their meaning of statistical significance is based on the spirometry software they're using and the comparison of the um, measured lung, like pulmonary function tests, with what what is generally called an LLN, or lower limit of normal, which is effectively the fifth percentile for a patient's, kind of roughly for patients given age, sex, height.
Yeah,
Essentially, what would be the lower limit that we would expect for normal?
but I
There's a
I
really
think in this case though, the whole idea of using inferential statistics is just it could be applied a lot better than what they're doing here because
I
what
don't
we
think
want
they
to
do
know
use
with
inferential statistics. I think this is a misuse of the term statistically significant.
well exactly
Um,
that's what I mean. So they're
yeah,
they're using they're using the term as though that's what they're doing, but that's not actually what's going on here because they didn't actually
correct.
make a hypothesis, choose a population, sample the population in a way that is justifiable, and then try to say how well does my sample, do I think that that represents the population. They just uh,
They took a single
they threw
data point
statistical software.
essentially.
Yeah,
Well,
I mean
it's not even statistical software. It's the spirometry software flagging a a measurement as outside of the range of normal. So that is, you know, quote unquote statistically significant in the sense that it's significant to the software. It's
yeah,
flagged. It's outside of our. It's below our fifth percentile. So we're saying it's really, in my opinion, a misuse of the term. It's also a fundamental misunderstanding of how spirometry measurements should be used.
well, and
Their
also
own.
anytime somebody talks about statistical significance, they really need to say what test they're using to generate statistical significance and how they're
Correct.
judging that. And that's not really mentioned here either.
I will say, strictly speaking, based on the very guidelines that they cite, they're kind of misinterpreting these spirometry tests as well.
Yeah.
The fifth percentile lower limit of normal is a reasonable trade-off. We kind of get back to our old biostats like sensitivity, specificity. You have to ultimately choose an arbitrary cutoff to say, well, we're okay with a certain percentage of people who may have a normal physiological variant being flagged as potentially having a particular, say, obstructive lung disorder, because we want to make sure we catch the greatest, the greatest number of people. So if you were to go and bring in your 45-year-old who has a 20 plus year pack year history of smoking and you're evaluating them for COPD, a fifth percentile lower limit normal is fairly reasonable. In a young healthy athlete, um, you might drop that down to the 2.5 percentile, or something a little bit more stringent, because our expectation is this person does not in fact have an obstructive lung disease. Um,
I think
so
one of
I
the
I
main
think
I think one of the main things that we're getting out of this is that people when they're interpreting data from studies like this just need to be really careful about not not just going along with what the authors are
Absolutely.
saying in terms of the methodology or the study style, because really it would be most accurate to call this a case series, I think. And they do say that somewhat later on, that this is essentially a series of 8 patients. But there was no
Of course, they
rigorous methodology behind sampling strategy. There was no intent to
yeah.
blind or control. So by calling it a prospective trial, they're implying those things, but that's not at all what was given to us.
They do explicitly call this a case series, which I have to question why they put that in their discussion and didn't then just label this as a case series, because then in the very next sentence they go on to say, in the description, they said 1 in 5 players who received this expanded screen and thus treatment had a clinically significant improvement in lung function. And then direct quote, in other words, there is a 20% chance of receiving clinically significant OMT results using their expanded zinc screening, which is
Yeah.
quite a claim.
Well, and they're
Um,
not they don't that's not what this study really does. You know,
no,
I almost feel like we got promised a charcuterie board, but what they handed us was a Lunchables.
I Lunchables that was maybe missing the meat and the cheese and was just some crackers.
Crackers and a crunch bar.
I sorry, go ahead,
No, no,
Corey.
no,
Were you
no.
gonna
No, I just
move us
making the
along a
joke.
little
No,
bit?
I just so the one thing that kind of like jumps out at me, is also too, and this is something that we kind of highlighted in some of our previous episodes. There's a kind of a pretty slim references section to kind of back up their, uh,
There are 5 references
yeah.
in this article for our listeners who don't want to spend the time reading it. There are 5 total references. 3 of which are really related to spirometry and are guidelines for how to interpret spirometry data. So do with that what you will.
So what are your recommendations for work on this topic, or
This,
moving forward with, is this another bring back to the bedrock and try it
this
over?
kind of study, is really really frustrating because I there's a part of me that I really want to encourage research at all levels. I don't like the idea of telling people that research they're doing is bad or that they shouldn't be doing it. But in this case, a study like this is incredibly frustrating because there are failures at almost every stage. Um, the introduction is lacking any sort of real compelling argument for why we're doing this. The methodology is, there's an attempt at good reporting, but they really don't don't achieve that, I think.
There's a lot
The
missing.
results are reasonably comprehensively reported, but then they only include spirometry data for 3 of their patients for reasons that I don't quite understand.
A lot of this
And
makes me
then
wonder what's happening at the peer review stage.
which is exactly, I
Hmm.
think and all of this comes together, which then the obvious question that I have to ask is, what a journal editor read this, presumably multiple peer reviewers read this, and my suspicion is that some of the strange things that we're seeing in the discussion are probably a result of the peer reviewers asking a lot of the same questions that we're asking now. But then I have to ask, why were they not addressed differently? Why did the authors
Yeah.
not take the opportunity to reframe this into a more reasonable result? Because I don't think that this is a completely worthless case study if it was framed as such. It's certainly interesting what they're trying to do. I think kind of expanding or modifying the vocabulary with which we diagnose and sort of standardizing it is a really good idea, is kind of a noble goal, but it stumbles and falls over itself into this um, this kind of like not quite a study that has really, really, really overblown conclusions.
Mm-hmm.
Yeah.
Well, thanks for bringing this article to us for this episode and everything for us to break down. It's good that we look at study articles that are all breadth of quality and everything, because we're trying to just break it down what's out there in publication and really just promote forth good practices for people that are listening, and just helping move forward just with this professional banter, per se, that's included in these episodes about really, what's best for manipulative therapy research and the practice as a whole moving forward. And so we don't mean any disrespect, but it's good to hear these critiques and breakdown, I think, and just to spur more conversation to get people's minds moving on this type of, topics. And so with that, we do want to thank Al and Steven for being with us in this episode. Just a reminder, if you want to check out more that's happening in DO-Touch.NET, you can go to our website, which is DO-TOUCH.NET, DO-Touch.NET, to see what's happening within the Practice-Based Research Network. And if you want, you can always join. We are free to join, and we are always welcoming more people that want to expand upon research of osteopathic manipulative medicine across the world. Thank you, Al and Steven, for being with us this episode, and we will talk to you all next time.
Thanks.
Yeah, thank you.